So this is really the first clinical talk for the fellows. Some of the participants have been here for a couple of days for the Biologic Alliance meeting or association meeting. And so there may be some redundancy, but what we're trying to do in this session is to compartmentalize everything and put it together very cleanly, topic by topic or pathology by pathology. So what I'm going to do is just review issues pertaining to tendon and try to give you some take-homes and to make sense out of what we think we know and is supported by our own experience and then maybe more importantly in the literature. All my disclosures, like everyone speaking today, will be in the Academy repository for full disclosure. So why is this even an issue when it comes to tendon? Out of all the musculoskeletal ailments that you and I will see, tendinitis and soft tissue injury still remains the #1 cause of visit for a physician in the area of sports medicine. So 4.5 million sports injuries require medical attention. There's probably 6 million people over the age of 60 are walking around with rotator cuff tears, despite the fact that we're only repairing about 250 to 300,000 of them. And then problems with poor biology lead to issues with recurrence, such as a 40 to 60% re-tear rate in a chronic massive tear. Doesn't always associate with poor outcomes clinically, but we know that biology is sort of the low-hanging fruit, and that's why some of our efforts are dedicated towards the treatment of tendon problems, because this is the area that we still have some of the greatest issues. When it comes to the rotator cuff, what we're trying to get is regeneration of the enthesis, and specifically this is a mineralized fibrocartilage layer. So what happens is there's this transition from tendon to fibrocartilage to mineralized fibrocartilage to bone. That's kind of how we all start out. One of the challenges once we have or undergo a rotator cuff repair, we generally heal with reactive scar or scarred in continuity, and we have a great deal of difficulty in regenerating the mineralized fibrocartilage. And there's a lot of reasons for this. The first reason probably has to do with the fact that there's an inflammatory response on top of lots of biologic challenges that leads to inflammation, and we heal with scar in continuity or fibrosis. That's probably the biggest challenge to actually recreating the enthesis. And if we're going to come up with some paradigm to say, what are we going to do to sort of regenerate tendon? And like any paradigm in sort of this concept of regenerative medicine, if you will, it's not going to be all about a progenitor cell or just growth factors or even a scaffold. It's going to also include the blood supply. Blood supply is insanely important to any healing environment. And that's one of the common denominators that we see as we age. The blood supply deteriorates. So unless we have good blood supply and can combine all of these things in sort of the three prongs of the stool, a cell, a growth factor, and a scaffold, we're probably never going to achieve the things we're trying to do so and going to talk about over the course of the next day and a half. So bringing it home and being very practical, what we have available, there really are limited options in the United States. And the things that you're going to hear most about and have to make heads or tails of is PRP and bone marrow concentrate. So I always like to start with just a bit of basic science. The challenge, though, is it may sound great and very supportive. What we've learned is that what happens in vitro doesn't necessarily translate into what's happening in vivo. And we are often doing very well in vitro, maybe a little bit okay in animal studies, and then we fall short in demonstrating clinical differences in humans. And that's a common trend that we're seeing across all of these orthobiologics. But suffice it to say, we still need a foundation more than intuition to say this kind of makes sense to be doing this, okay? So the basic science of PRP and rotator cuff disease, this is a fairly straightforward co-culture study that we performed in collaboration with Lisa Fortier's lab. And we basically took retrieved diseased rotator cuff tendons and assayed how they performed with leukocyte-poor versus leukocyte-rich PRP. And the take-home was that in culture with diseased rotator cuff tendon, that leukocyte-poor PRP promoted collagen synthesis and decreased catabolic cytokines versus leukocyte-rich PRP in degenerative tendon. So there's some sort of basis or thesis that we're trying to develop. The other sort of intuitively positive aspect of PRP is that it actually signals for MSCs. So all of us, as we know, have host MSCs that function in various ways, and maybe simply just a paracrine type effect, or to induce a local healing response, because indeed we want to heal. If we can remove some of the biologic and biochemical challenges and biomechanical challenges, our bodies inherently want to heal. So PRP has been known in a variety of different models to actually signal for our own endogenous MSCs. So that might be particularly important in healing. So what do we know about PRP and the rotator cuff? So this is a slide that's adapted from Jorge Chala, one of our current partners. And essentially, it's like a mini meta-analysis to say, hey, where and when does it work? And you got to be a little careful about generalizing the outcomes to just a single take-home that we should be using PRP in all rotator cuff repairs. I will tell you that when you get down to the level of level 1 prospective randomized controlled trials, the take-home is the following. It seems to work more affirmatively if it's placed at the bone-tendon interface. There is a suggestion that there's a statistical benefit in double row repairs, and that the ones that showed the greatest differences in healing rates were small and medium tears. And all sizes did okay or well if it was PRP, but not PRP with fibrin. So if PRP fibrin matrix seemed to actually inhibit and not help. So that's sort of the general take-home. So are we ready for prime time for every rotator cuff to use PRP? In the end, we still have to have good surgical principles, more importantly, good surgical indications, because not everyone who has a rotator cuff tear needs to have it fixed, okay? That's why we have 6 million people running around and have no idea they have a cuff tear because they're all well compensated and adapted. But when it comes time to fix them, a good operation is what's required. That being said, we're still dealing with poor biology, and PRP is not the whole story, but there may be some incremental benefit, save for issues of cost and efficiency, which have to be taken into consideration as it's an unreimbursable therapy. It's cash pay. Okay, you're going to hear a lot about this concept of connective tissue progenitor cells, and it's not that our bodies don't have stem cells, and it's not that what you're getting in a bone marrow aspirate is not a stem cell. The concept is that in vitro, we can get them to behave as stem cells with downstream recreation of musculoskeletal tissue, but that's not the way they're behaving when you and I use them in a therapeutic setting. So that's the take-home. When Arnie Kaplan talks about it, he doesn't say, well, the stem cell doesn't exist. He's saying the way we're using them and harnessing their abilities, which might have some benefit, has little or nothing to do with their ability to transform into different cell types of musculoskeletal tissue. So I think that's the important take-home. So people were leaving this room yesterday and the day before saying, well, I guess there's nothing to do with stem cells anymore. We all suck and they don't exist. So it was a very confusing day for people when that's the first time they heard it. It doesn't mean they don't have impact or possible positive effects, and I would say the take-home is that they probably work as Dr. Kaplan and others have talked about, and if you want to keep the term MSCs, don't call them mesenchymal stem cells. As the way they function, their function may be attributed to various bioactive factors that might recruit MSCs to the area, just like PRP might do, and may secrete bioactive growth factors to do all of these things. And some of the most important aspects of the way they might or could function have to do with modulating the immune system and being anti-inflammatory in nature. So that's not how a stem cell functions by the criteria of a stem cell, but that doesn't mean it has zero benefit either. It's our job to prove that it actually has some benefit. So I think that sort of hopefully puts it in a nutshell. You're going to hear this over and over again today. So are they clinically relevant when it comes to the rotator cuff? It's an interesting study that looked at patients it was a Hernigau study that looked at patients who did and did not have rotator cuff tears. And essentially taking bone marrow aspirate and concentrating from the greater tuberosity, he showed that patients without a rotator cuff tear had more MSCs. So the take-home is that might be a vascular phenomenon, that may be a chicken or egg phenomenon, we don't know. Maybe the cuff tear leads to change in MSC content, but it's implying that there's probably some either blood dyscrasia, angiopathy, something that's going on in blood supply and or local milieu within the bone marrow of the greater tuberosity in patients who have rotator cuff tears. But it helps to build the thesis that they may have some relevance. This is a study that we looked at from one of my former fellows at the rotator cuff tendon to sort of get an idea of if we ever want to manipulate these cells in an endogenous way and use them for therapeutic measures, where do they live and how do they perform? And the premise was that can we get the same genetic expression and or functionality, if you will, through culture, CFU analysis, and so forth, when we take cells or samples from the tendon, the muscle tendon junction of the muscle. And what we showed is that the tendon looks a lot like the muscle tendon junction. And we feel that's important because we may want to stay away from the tendon when it comes to harnessing therapeutic value of local tissue and move a bit more medially if we're contemplating using local tissue to make a difference. And I'll give you an example of that. So what are the clinical outcomes when it comes to the use of bone marrow? I showed you what it was for PRP. What are the clinical outcomes when it comes to bone marrow concentrate and adipose as a source of potential MSCs or having a paracrine effect? There are two studies in the literature. The Herringau paper is the one you'll often see, and that's a matched case control study looking at bone marrow concentrate and rotator cuff comparison of 45 patients, looking at them at 10 years, and by ultrasound, taking bone marrow concentrate from the ASAS, and I believe the difference here is they use 120 cc's, and they did show some response rate based upon the number of MSCs that were presumably present. But they had retear rates that were 87%, and that was in that population that was augmented by bone marrow concentrate versus 44% in the non-bone marrow concentrate at 10 years. Pretty profound differences. And there was a second study looking at adipose-derived mesenchymal cells that was a level 3 matched control group showing an MRI difference in anatomic integrity of 28 versus 14 when the adipose is present. Just to show you our results, we're about through with the study, but I'll just give you the preliminary results in this one slide where we have a randomized study, multiple investigators using bone marrow concentrate from the iliac crest, showing a 1-point difference on the SIGAIA scale, which is a 5-point scale looking at the integrity of the cuff at 1 year by MRI. So we're showing a 1-point difference that appears to be statistically significant at this juncture in anatomic integrity. I got nothing for you on the clinical side, but I'll just tell you on anatomic integrity, that's where we're at. There are some other options that have been investigated. People have looked at MSCs for the treatment of rotator cuff disease for interstitial tears and have shown that it will resolve bursal defects. That has not been shown with PRP in the same type of study, but this study actually showed if you inject it with autologous cultured adipose MSC, something you're not going to do, might resolve a bursal defect. The other area that I was sort of alluding to before is that there's some data that in the area of the bursa, where the bursa may actually be a very rich source of pluripotent cells or progenitor cells, and this may be a poor man's way to harness the body's own ability or willingness to heal by just taking bursa. Maybe we chop it up, we're not going to digest it with collagenase, we're going to keep it minimally manipulated and putting it back in to see if it has some beneficial effect. You're going to see a lot about this over the course of the next year. So I'm just going to blast through, give you some take-homes on one slide on each, I believe, because they asked me to talk about tendons in general. So where are we with PRP and lateral epicondylitis? There's lots of studies and randomized controlled trials. The study that gets the most attention is the one on the top left, which is a double-blind study. And their general consensus is that it may have some benefit and can be placed into the algorithm that you might traditionally use, which could include corticosteroids and or physiotherapy and activity modification and tennis elbow bracing and so forth. Keep in mind, there's not enough evidence to say that this is a dominant treatment strategy as a first-line treatment. The onocollateral ligament is interesting because most of what was published initially were case studies, series that looked very favorable. When the MLB looked at this, they found something pretty different, and they said, yeah, it might have some benefit for onocollateral ligament tears, but we didn't find them getting back to play any sooner. And this is actually from multiple providers for multiple MLB teams. So I would say that it should be yellow, even though green has shown some benefit. Just like lateral epicondylitis, we're including this in our treatment algorithm because it's do no harm, and it might just help put a player or an athlete in a position where they can avoid a 6 to 8 to 12-month recovery. So it does have merit in that regard. I would say that discussion or narrative is the same thing for patellar tendonitis. The unique thing about patellar tendonitis is we're not going to use cortisone for patellar tendonitis, right? So does it work for patellar tendonitis? I would submit to you that we have very limited invasive treatment options, this being an invasive treatment option for patellar tendonitis other than surgery. So many of us are gravitating towards it, and there's been some suggestion that it might benefit or offer an alternative. Recently, there was a study that you'll hear about in some other discussions perhaps that basically showed there was no difference and all things worked when they looked at leukocyte-rich versus leukocyte-poor or saline. All these patients got rehab for 6 weeks ahead of time. It's a randomized controlled trial. So the challenge is that they all worked, but they're not sure which one is better. That's the way I look at it. The flip side is that patients can be non-responsive to one treatment and then become responsive to others. So I think putting in the armamentarium is not irresponsible. Again, it may not be the first thing you're going to do when the patient walks in the office when most patients should respond to proper rehab, calf strengthening, and activities like that. They should get better. But if they don't and you're stuck, you're not going to use cortisone. This seems to be a potentially viable treatment option, and most of us would probably pick it over saline from an intuitive point of view. So this is an example of a high-level athlete who has patellar tendinosis, so we just happen to capture all the right data, painted the inferior pole, failed all the traditional things. And some people say, well, that's a tear. It's not really a tear in the true sense of the word. This is what basically every high-level basketball player looks like at the time they come in at combine. And essentially, this is one we will do under ultrasound. The reason we do it under ultrasound is because you can be fooled. The tendon can be pretty deep and you don't know where you're going. So you really want to go to the point of interest. So this is one where we'll routinely, intra-articulars we don't routinely use ultrasound, but here I will routinely use ultrasound. and just showing what the tendon looked like. It's a little like gee whiz. There was some thickening 6 weeks post-injection. He clearly ended up having reduced pain, some functional improvement, and actually got back to sport in about 6 weeks after having a very prolonged period of disability. So I think it's one that should be in the treatment algorithm. Achilles tendon, I would say most of the data speaks against it. There was one recent published study using autologous conditioned serum, which is supportive, but most of the foot and ankle people do not use it regularly. I think this might be one of the final ones. Amniotic tissue has some promise. This is a really interesting study, which I think was published in Foot and Ankle, that looked at plantar fasciitis. It was in a 2B study that went into a phase 3 study compared to placebo injections and looked at amniotic tissue, and they actually had a statistically significant improvement for chronic plantar fasciitis. So I know the foot and ankle surgeons have cued in on the use of amniotic in this application. What about the ACL? This take-home is, this is published in Arthroscopy, no differences when using PRP as an augment or adjunct to ACL treatment. So some final thoughts. There's very little clinical literature on MSCs and tendon treatment. I think PRP can be considered for augmentation of the cuff, lateral epicondylitis, notocollateral ligament, and patellar tendinosis. So just to summarize it, I think it's worth considering for patellar tendonitis. We don't have a lot of other things for it, and it might work. Achilles has had mostly a negative flavor in the literature. The lateral epicondyle and the notocollateral ligament seems to have pretty decent support. Again, never leapfrog over traditional treatments. And as far as the cuff goes, there's some suggestion that PRP may make a difference, and our study now is showing a 1-point difference by MRI that it might actually have some advantage when using bone marrow concentrate. Thank you very much.